Welcome back to the Deep Dive, where we take your complex medical queries, the ones you've brought to us, and really sort of unpack them. Our mission is to break down intricate clinical topics, draw out the most essential insights from a wealth of experience, and ultimately give you the clarity needed to feel truly well-informed. Today, we're diving deep into your specific questions about a common yet remarkably nuanced challenge in orthopedics: arthritis of the finger joints, and its enigmatic, often co-occurring companion, the digital mucous cyst. These conditions, while they might appear, fairly straightforward on the surface, they present intriguing diagnostic puzzles and a whole spectrum of treatment considerations that can truly challenge clinicians. For this deep dive, we're honored to have with us a distinguished expert in the field of orthopedic hand surgery. It's a genuine pleasure to have you join us to unravel this.
Thank you. It's a privilege to contribute to such a focused and important discussion for our colleagues. I always enjoy exploring these areas with such depth.
Absolutely. So let's unpack this for our dedicated listener. Our deep dive today is going to thoroughly explore the epidemiology, pathophysiology, and the very latest management strategies for distal interphalangeal, or DIP, and proximal interphalangeal, or PIP, joint arthritis. We'll also take a detailed look at digital mucous cysts, considering their unique challenges. Ultimately, we're aiming to provide you with a clearer, more precise understanding of when to observe, when to intervene, and crucially, how to optimize patient outcomes for these often frustrating conditions. So let's begin with the fundamentals. When we talk about arthritis in the finger, specifically affecting the DIP and PIP joints, what are the primary forms clinicians really need to be acutely aware of, and how do they manifest differently in our patients, sometimes quite subtly?
Indeed. Arthritis of the DIP and PIP joints is incredibly common. It represents some of the most frequently encountered forms of osteoarthritis in the hand. As orthopedic professionals, it's absolutely crucial for us to differentiate between primary osteoarthritis and erosive osteoarthritis. Their underlying mechanisms and, critically, their clinical implications diverge significantly, which profoundly impacts our management approach. You really do need to tell them apart.
Okay, so two distinct types there.
Exactly. Primary osteoarthritis, which many of us see day in and day out, is characterized by a progressive degeneration of the joint cartilage and underlying bone. In the DIP joints, this form is very frequently linked to high joint forces. Think about the repetitive pinching, gripping, fine motor skills our fingers perform daily. These forces lead to more wear and tear over time, slowly degrading the joint. Clinically, a classic and very visible sign here is the presence of Heberden's nodules.
Yes, the bony lumps.
Precisely. They're essentially osteophytes, or bony spurs, that slowly develop at the joint margins, giving the finger that knobbly, enlarged appearance. For the PIP joints, we observe similar osteophytic changes, commonly known as Bouchard nodes. These nodes are often accompanied by joint contractures due to a gradual fibrosis of the surrounding ligaments, limiting full range of motion. So with primary OA, you're generally looking at a slow, progressive change, often with these characteristic palpable nodular formations that patients themselves frequently notice and find concerning.
Right, they often come in saying their knuckles are getting bigger.
Exactly that. Now, erosive osteoarthritis, on the other hand, is a distinct and often far more aggressive entity. While its symptoms can, perhaps surprisingly, be self-limiting for some patients, they might experience acute flares but then have sort of quiescent periods. The condition itself has a far more destructive effect on the joint.
More destructive? How so?
Unlike the gradual wear and tear of primary OA, erosive OA involves significant rapid articular cartilage and adjacent bone destruction. Clinically, it presents with distinct intermittent inflammatory episodes. Patients will describe acute pain, swelling, warmth, redness. And on examination, you'll see synovial changes that can, at first glance, mimic rheumatoid arthritis.
Okay, so it looks inflammatory.
Very much so. But critically, it lacks the systemic manifestations like symmetrical polyarthritis or specific serological markers we associate with true rheumatoid disease. From an epidemiological standpoint, it's also noteworthy for its prevalence, being significantly more common in middle-aged women, with a striking 10.1 female-to-male ratio.
10 to 1. That's remarkable.
It is, and it raises an important question that continues to intrigue researchers. What are the underlying mechanisms? Perhaps hormonal influences, genetic predispositions, or specific inflammatory pathways that might be driving this particularly aggressive form, predominantly in this specific demographic. Understanding these stark differences allows us to immediately begin to tailor our diagnostic and management approach, moving beyond a one-size-fits-all perspective.
That's a vital clarification. It sounds like differentiating between primary and erosive OA is absolutely paramount, not just academically, but for guiding our initial patient conversation and diagnostic workup. So beyond those visible nodes and those hallmark inflammatory flares, how do these fundamental differences in the nature of the disease truly influence our initial assessment when a patient first walks into the clinic? What's the immediate shift in our thinking?
Excellent point. The immediate shift is in our diagnostic suspicion and the questions we ask. From an epidemiological perspective, it's worth noting that DIP arthritis is actually the most common form of arthritis in the hand.
More than the thumb base.
Even more so than thumb carpometacarpal, or CMC, joint arthritis, yes. This is followed by PIP, and then metacarpophalangeal, or MCP, joint involvement. This order of incidence is crucial for clinicians, as it guides our initial diagnostic suspicion and helps us prioritize our differential diagnoses based on the presenting joint. You're thinking, okay, if it's the DIP, primary or erosive OA is highly likely.
Right, it primes your thinking.
Precisely. Now, patients with primary osteoarthritis typically present with pain and a slowly progressive deformity. The pain itself could vary widely in intensity. Some individuals experience a chronic dull aching that's more noticeable with activity, while others might report sharper pains with specific movements. However, it's often the visible changes, such as the gradual development of those palpable and sometimes quite prominent evidence or Bouchard nodes, that truly drive them to seek medical consultation.
The appearance bothers them.
Often, yes. We've all seen patients who come in saying, "My fingers are just getting knobbly, doctor." In the DIP joint specifically, the nail can also be significantly involved. Patients may complain of nail splitting, ridging, or a noticeable loss of gloss due to pressure from the underlying osteophyte or cyst. For some, this nail deformity, rather than significant pain, might even be their primary cosmetic concern, overshadowing any functional pain they experience.
That's interesting, the cosmetic aspect being primary.
It is. And this cosmetic impact, especially for those whose hands are central to their profession or self-image, shouldn't be underestimated in our patient discussions. Conversely, patients with erosive osteoarthritis often describe quite distinct symptoms. They'll typically report intermittent, acute inflammatory episodes.
The flares you mentioned.
Exactly, the flares. These can be profoundly painful, accompanied by intense swelling and warmth in the affected joints. Imagine a patient describing a sudden, severe flare-up, almost like a hot, throbbing sensation. Despite the potential for significant cartilage and bone destruction evident on imaging, the periods between these acute flares might be relatively asymptomatic, which is a key diagnostic clue.
So they feel okay between episodes.
Relatively speaking, yes. And this intermittent nature can sometimes delay presentation or accurate diagnosis if the inflammatory component isn't fully appreciated by either the patient or the initial evaluating clinician. It's absolutely vital to specifically inquire about these flares, their frequency, intensity, duration, and the patient's history to correctly identify the erosive variant, as the management implications are different.
That really paints a clearer picture of the initial presentation. So once we have that strong clinical suspicion based on history and physical examination, what are the essential diagnostic tools at our disposal? And what specific findings should we be looking for to confirm the diagnosis and guide our management, especially to definitively distinguish between these two forms you've so clearly described?
Well, the diagnosis is indeed confirmed by a robust combination of a detailed clinical history, a thorough physical examination, and crucially appropriate radiographic imaging.
So X-rays are key.
Absolutely. For hand arthritis, the recommended views are pretty standard: anterior posterior, or AP lateral and oblique radiographs of the hand. These views provide the comprehensive visual information we need. On radiographs, we're meticulously looking for clear, unambiguous signs of joint degeneration. This includes the hallmark features such as joint space narrowing, which directly indicates cartilage loss.
Right.
The presence of osteophytes, those bony proliferations at the joint margins we discussed, and subchondral sclerosis, which is increased bone density immediately beneath the cartilage, reflecting the bone's reactive response to abnormal stress.
Okay, those are the classic OA signs.
Yes, but for erosive osteoarthritis, the radiographic picture is even more characteristic and, frankly, quite telling. Here we'll observe significant cartilage destruction that's often more pronounced and rapid than in primary OA, along with distinct osteophytes and, most importantly, subchondral erosion. This erosion can lead to a very specific and, well, almost pathognomonic appearance described as a gull wing deformity.
A gull wing, can you describe that?
Yes. Imagine the central part of the joint surface seems to have collapsed or eroded away, creating a shape reminiscent of the outstretched wings of a gull on the X-ray. This finding is highly suggestive of erosive disease and decisively differentiates it from typical primary osteoarthritis. It's absolutely critical for clinicians to understand and recognize these distinct radiographic patterns as they directly inform and allow us to tailor our treatment plan effectively. It's about moving beyond just symptomatic relief to address the specific pathological processes at play. This is one of those aha moments in diagnosis that truly changes the patient's journey.
Right, seeing that gull wing really points you in a specific direction. Fascinating. Okay, let's shift gears slightly. Digital mucous cysts. These are a fascinating and often co-occurring condition with DIP joint arthritis. They seem to be more than just a simple bump. What exactly are these cysts, and what do we understand about their origin and how they develop? They often present a puzzle for patients and clinicians alike.
That's right, they can be puzzling. Digital mucous cysts are essentially a type of ganglion cyst. They present as benign, fluid-filled lesions that typically appear on the dorsal surface of the fingers. They are almost exclusively found overlying the distal interphalangeal, or DIP, joint. What's absolutely key here, and often the first clue to their nature, is their common and strong association with underlying osteoarthritis of that very same DIP joint.
So they nearly always go hand in hand with the arthritis.
Very often, yes. This association isn't just coincidental, it points to a deeper connection in their etiology, suggesting they are a manifestation of the underlying joint pathology. While the exact etiology of digital mucous cysts remains somewhat unknown, the prevailing theories firmly link them to the underlying DIP joint osteoarthritis. One prominent theory suggests these cysts are an outpouching of the synovial lining of the joint.
Like a little hernia of the joint lining.
Sort of, yes. Evidence for this comes from studies where dye is injected into the joint, which have successfully shown communication between the joint cavity and the cyst. Interestingly, the reverse isn't typically seen. When dye is injected into the cyst, it doesn't usually flow back into the joint.
Ah, a one-way street.
Exactly. This observation strongly implies a one-way valve mechanism. Imagine a slow leak. Synovial fluid is able to escape from the joint into the surrounding soft tissue, but for some reason cannot easily return. This continuous low-pressure leakage could contribute to the cyst's gradual growth and expansion.
Okay, that makes sense. What about other theories?
Well, another compelling theory proposes that kissing osteophytes, or bone spurs, emanating from the DIP joint, actively puncture the joint capsule.
Kissing osteophytes, so spurs rubbing together.
Or perhaps one spur repeatedly impinging on the capsule. This creates a small defect through which synovial fluid then extravasates into the soft tissues, forming the cyst. This theory is robustly supported by clinical observations and studies. For example, one by Eaton found that all mucous cysts excised where marginal osteophyte resection was also performed demonstrated direct communication with the DIP joint.
So removing the spur is key then?
Absolutely. This finding truly underscores the profound importance of addressing the underlying osteophyte during surgical management. It's not just a bystander, it's an active participant, acting as the conduit for cyst formation. Histologically, when we examine these cysts under the microscope, we find they are multilobulated with walls composed of randomly oriented collagen fibers. Inside, they are filled with a characteristic viscous, clear to yellow mucin, which is notably rich in hyaluronic acid, along with globulin, glucosamine, and albumin. This composition gives them their distinctive gelatinous consistency.
That jelly-like fluid patients describe.
Precisely. This understanding, particularly the role of the osteophyte, is a game-changer for guiding our approach to treatment, emphasizing that merely draining the cyst won't suffice if the underlying bony pathology isn't addressed.
That explanation of the one-way valve in the kissing osteophytes truly demystifies their origin. It also highlights why they're not just a simple cosmetic issue. How do these digital mucous cysts typically present to us in clinic, and what are some of the complications we need to be vigilant for beyond just the lump itself, particularly with their close proximity to the nail?
Patients usually present with a slow-growing mass, typically located on the dorsal aspect of the DIP joint. These cysts are generally firm to palpation, round, or dome-shaped.
Can you see through them? Transillumination?
Often, yes. They can often be transilluminated, which is a useful clinical sign that helps differentiate them from solid tumors. Interestingly, they often arise slightly off midline from the DIP joint, pushed by the extensor tendon, though they remain attached to the joint by a stalk. While many of these cysts are painless, larger ones can certainly cause discomfort, especially with direct pressure or movement. I recall one patient, a professional pianist,
Ah, yes.
whose cyst, though small, caused significant pain with pressure on the keyboard, impacting her livelihood. So function can be affected.
Right. And the complications. You mentioned the nail.
Yes, here's where it gets really interesting for clinical practice and why vigilance is essential. A significant and often distressing complication is nail deformity. If the cyst exerts pressure on the germinal matrix of the nail, which is the tissue responsible for nail growth, it can lead to longitudinal grooving, splitting, or ridging of the nail plate.
And patients really hate that.
They do. For some patients, this nail deformity, rather than pain, is the primary reason they seek medical attention. Imagine a patient who is constantly catching their nail on closing or experiencing embarrassment. Furthermore, the skin overlying the cyst can become extremely thin, shiny, or even ulcerated due to continuous pressure and inadequate blood supply.
Making it prone to rupture.
Exactly. This compromised skin significantly increases the risk of the cyst rupturing, which can lead to drainage of the mucinous fluid and, critically, potential infection. An infection carries the serious risk of a septic DIP joint, which is a true surgical emergency requiring immediate intervention.
A septic joint from a ruptured cyst.
Wow, it's a serious risk. Other potential complications, though less common, include joint stiffness, which can impair finger function, damage to the extensor tendon overlying the joint, and in rare, severe cases, osteomyelitis, a bone infection. It is absolutely crucial to meticulously assess the quality of the overlying skin preoperatively, as this condition may dictate the need for complex skin coverage procedures during surgery.
So skin quality is a major factor in surgical planning.
A huge factor, yes. It ensures a successful outcome and prevents postoperative soft tissue defects.
It's clear that while seemingly benign, these cysts can lead to serious downstream issues. Given their appearance and location, are there other conditions that digital mucous cysts might be mistaken for in our initial assessment? What's the comprehensive diagnostic workup to ensure we have an accurate diagnosis and aren't missing something else, especially if the presentation is atypical?
An accurate diagnosis is vital, yes, not only for appropriate management, but also to differentiate digital mucous cysts from other soft tissue masses that might present similarly in the hand. The differential diagnosis includes things like gouty tophi.
Right, those chalky deposits.
Yes. Also giant cell tumors of the tendon sheath, which are benign soft tissue tumors, and even Heberden's nodes themselves. It's important to clarify that while mucous cysts are distinct lesions, they often coexist with Heberden's nodes, given their shared association with DIP joint osteoarthritis.
So you might see both, but they're different things.
Precisely. The cyst is a fluid-filled lesion distinct from the bony spur. While a thorough clinical examination, assessing the mass's characteristics and its relationship to the joint, is often sufficient to make a presumptive diagnosis, radiographs of the hand should always be obtained.
Always get the X-ray.
Always. These are essential not just to confirm the presence of the cyst, which sometimes isn't visible directly on X-ray, but critically, to identify the underlying DIP joint osteoarthritis. We're looking for signs like subchondral sclerosis, the presence of osteophytes, and joint space narrowing, as this underlying pathology profoundly influences both the treatment strategy and the prognosis.
So the X-ray tells you about the arthritis driving it.
Exactly. Additionally, for more ambiguous cases, perhaps those with atypical presentations like unusual pain or rapid growth, or for meticulous preoperative planning, advanced imaging techniques can be incredibly valuable. Ultrasound can precisely visualize the cyst's fluid-filled characteristics and its direct connection to the joint.
Useful for seeing that stock.
Very useful. And MRI provides excellent detailed imaging of soft tissue structures and their precise relationship to surrounding anatomical elements like tendons, nerves, and the delicate nail matrix. Ultimately, histopathological examination, typically following biopsy or excision, remains the definitive diagnostic method. Under the microscope, it reveals the characteristic mucin pooling and a fibrous capsule, and crucially, serves to definitively rule out any rare but possible malignancy.
Always important to rule out the nasties.
Always a consideration with any soft tissue mass in a differential diagnosis.
Okay, Professor, now that we've truly established the landscape of these conditions, how they present, what to look for diagnostically, the burning question for many of our listeners is, what do we do about it? So let's turn our attention to the array of treatment options available, starting with conservative approaches. For patients presenting with mild symptoms of DIP or PIP joint arthritis, or even a digital mucous cyst, when is a conservative approach appropriate, and what does that typically involve for each of these conditions?
Conservative management is always, and I stress always, the first line of treatment. particularly for patients presenting with mild symptoms that don't significantly impact their quality of life or functional abilities.
We'll start simple.
Exactly. For both DIP and PIP joint arthritis, this typically involves a combination of observation and the judicious use of nonsteroidal anti-inflammatory drugs, or NSAIDs, to effectively manage the pain and reduce inflammation. These can be topical creams or gels, which often provide localized relief with fewer systemic side effects, or oral medications, depending on patient preference, comorbidities, and systemic considerations.
Topical first, perhaps.
Often a good starting point, yes. Physical therapy can also play a valuable role in maintaining range of motion, improving joint proprioception, and strengthening surrounding musculature, though its impact on fixed osteoarthritic changes and bony spurs is naturally limited. It's about symptom control and functional preservation.
And for the cysts, watchful waiting.
For digital mucous cysts, observation is also the prudent initial approach, especially for small cysts that are not causing significant symptoms, skin compromise, or nail deformity. The reason for this is quite compelling. A significant proportion of these cysts, ranging from 20% to as high as 60% in some published series, can spontaneously resolve over time without any intervention.
Really? Up to 60%.
It's surprisingly high. So a period of watchful waiting with patient education about what to look out for is often warranted. Aspiration of the cyst using a needle to drain the fluid is another non-operative option that can provide temporary symptomatic relief by decompressing the cyst.
Sticking a needle in, does it work?
It provides temporary relief, but it's absolutely vital that patients are thoroughly counseled on the very high recurrence rate associated with aspiration alone, which can be around 50%.
50% recurrence.
It's often a disappointing outcome for patients who expect a definitive solution, and it's a point of frequent frustration in clinic. Now, a crucial point here, which I cannot overstate enough for our clinical audience, is to avoid corticosteroid injections directly into the cyst.
Right, you mentioned this earlier. Why is that so bad?
Well, it might seem tempting to inject a steroid for its powerful anti-inflammatory properties and to potentially shrink the cyst. These injections carry significant risks in this delicate anatomical area. They can lead to severe skin thinning, compromising an already delicate dorsal skin envelope, and are associated with a very, very high recurrence rate, potentially as high as 68% to 100%.
Wow, almost guaranteed to come back and you thin the skin.
Precisely. And this raises that important question. Why might a short-term symptomatic relief strategy lead to such a poor long-term outcome and even exacerbate local tissue problems? The answer, as we discussed earlier, lies in the fundamental pathophysiology. It simply doesn't address the underlying issue of the joint connection and the ongoing extravasation of synovial fluid from the joint, nor does it remove the causative osteophyte.
You're treating the symptom, not the cause.
Exactly. You're treating the symptom, not the root cause, and in this specific case, potentially causing lasting harm to the overlying skin. So please avoid steroids in these cysts.
That's a powerful warning. It really reinforces the importance of understanding the underlying pathology. So when conservative measures aren't sufficient and we're looking at more debilitating symptoms or significant deformity, what surgical options are available for the primary arthritis itself, particularly in the DIP and PIP joints? And what are the key considerations for choosing between these options, which can have very different functional outcomes?
Well, when symptoms are indeed debilitating, or there's significant deformity leading to functional impairment that impacts a patient's daily life, surgical intervention becomes necessary to restore function and alleviate pain. For DIP joint arthritis, arthrodesis, or joint fusion is generally considered the primary and most reliable operative treatment.
Fusing the end joint.
Yes. Its goal is to eliminate pain by stopping motion at the joint, achieving a solid, stable union. For DIP joint fusion, the technique typically involves fusing the joint with a headless compression screw. This method offers the highest reported fusion rate, often exceeding 90%, with relatively low non-union rate of approximately 10%.
So it usually works well?
Generally, yes, but the positioning of the digits during fusion is absolutely critical to ensure optimal hand function and a natural aesthetic cascade. Specifically, the second and third digits, the index and middle fingers, are usually fused in full extension.
Straight out. Why?
To facilitate precision pinch and grasp, which are crucial for tasks like holding a pen or manipulating small objects. In contrast, the fourth and fifth digits, the ring and small fingers, are fused in 10 to 20 degrees of flexion. This slight progressive flexion from radial to ulnar helps maintain a natural and aesthetically pleasing cascade of the fingers when the hand is at rest and during power grasp, ensuring they don't awkwardly stick out.
Ah, I see, to keep that curve.
Precisely. Risks associated with this procedure include using too large a screw diameter, which could risk a fracture through the phalanx, and potential nail bed deformity if the screw interferes with the germinal matrix. Furthermore, a screw that is too long can result in prominent hardware distally, which can cause significant fingertip hypersensitivity and discomfort.
Ouch, yeah. What about the PIP joint? More options there.
For PIP joint arthritis, the surgical options are a bit more varied, depending on the specific presentation and the patient's functional demands. If a predominant contracture exists with minimal underlying joint destruction, meaning the joint itself is relatively well preserved, procedures like collateral ligament excision, volar plate release, and osteophyte excision can be considered.
Sort of a tidy-up procedure.
You could call it that, yes. These aim to release the soft tissue contracture and improve range of motion without sacrificing the joint itself. However, if the joint pathology is more advanced, fusion remains a strong option. Fusion is generally indicated for the border digits, meaning the index and small fingers.
Why those specifically?
Because these are critical for strong pinch and power grip, where stability is often prioritized over mobility. It's also a robust option for middle and ring finger OA, especially if there's significant angulation or rotational deformity, severe ligamentous instability, or poor bone stock that would preclude arthroplasty.
Right, if the joint's really unstable or crooked.
Exactly. Again, headless screw fixation provides very high fusion rates for these joints, with specific, carefully chosen flexion angles to recreate the normal cascade. Index at 30 degrees, long at 35, ring at 40, small at 45 degrees.
That graduated flexion again?
Yes. It ensures maximal function during grasp and a natural hand appearance.
Okay, so fusion is an option. What about replacing the joint? Arthroplasty.
Yes, for the central digits, namely the long and ring fingers, silicone arthroplasty is an alternative to fusion, provided there's good bone stock and no significant angulation or deformity. Unlike unconstrained pyrocarbon implants, linked silicone implants do not rely on soft tissue competence, such as perfectly intact collateral ligaments and volar plate for their inherent stability.
So the implant itself provides stability.
To a degree, yes. However, it's vital that the radial collateral ligament remains intact in these fingers, as it is crucial for tolerating pinch grip and preventing ulnar deviation. This highlights a fascinating trade-off. While studies consistently show significant improvements in pain with silicone arthroplasty.
Which is good.
Absolutely. But it's an important clinical pearl that there's often no significant improvement in PIP joint range motion, grip strength, or overall outcome scores, despite the pain relief.
No better movement or strength, just less pain.
Often, yes. This is largely because the silicone implant acts primarily as a spacer, restoring joint height and alignment to reduce pain and allow smooth tendon gliding. But its inherent design and the limitations of the surrounding soft tissues often prevent a significant increase in active range of motion, unlike a natural joint or certain alternative implants focused solely on mobility.
That's surprising. Patients might expect more movement.
They're right, which is why preoperative counseling is so important. Furthermore, the volar approach for arthroplasty tends to yield better postoperative range of motion and a lower revision rate compared to the dorsal approach, due to less disruption of the extensor mechanism. This nuanced outcome means meticulous patient selection and comprehensive preoperative counseling are paramount, ensuring the patient's expectations align with the likely functional gains.
That's a really important distinction, the idea that silicone arthroplasty can bring pain relief without necessarily significant functional gain. It sounds like patient expectations are absolutely key there. Now, given their close association with DIP joint arthritis, how does the surgical management of a digital mucous cyst intersect with, or perhaps differ from, treating the underlying arthritis itself? It seems like it's not just a matter of removing a superficial lump, but something far more fundamental.
You've hit on a crucial point, and this is where understanding the pathophysiology truly guides our hand. Surgical management of a digital mucous cyst is primarily aimed at decreasing the risk of recurrence. It's typically chosen when conservative treatment fails, or when complications like problematic skin thinning, impending rupture, or painful nail deformities arise. The key, and this cannot be overstated enough, is not just about removing the visible cyst itself. It's about performing a comprehensive excision that crucially involves removing the stalk of the cyst, the dorsal capsule, and critically, debriding any associated osteophytes from the underlying DIP joint.
Back to those osteophytes again.
Always back to the osteophytes. This meticulous removal is paramount because, as we discussed, they are widely believed to be the root cause of the cyst, acting as that one-way valve or point of extravasation. Studies clearly demonstrate that addressing and removing these underlying osteophytes dramatically reduces the recurrence rate to less than 10%.
Less than 10% if you get the spur.
Correct. Conversely, if the osteophyte is not debrided, recurrence is highly, highly likely, negating much of the surgical effort. This is the absolute game changer for long-term patient outcomes with these cysts.
So the message is, excise the cyst, the stalk, the capsule, and the osteophyte.
That's the mantra. Meticulous surgical technique is absolutely required due to the intricate anatomy and the close proximity of vital structures in the fingertip. We must be particularly careful to avoid damaging the germinal matrix of the nail. It's often much closer to the operative field than one might expect, potentially up to 5 mm proximal to the epinicium fold.
Very close indeed.
Yes. Various incision patterns can be used H-shaped, T, inverted U, or transverse depending on the cyst location, size, and skin quality. During dissection, extreme care must be taken to protect the germinal matrix and the extensor tendon. The cyst is carefully immobilized, its stalk traced down to the joint capsule, and then excised along with a portion of the capsule, ensuring the osteophytes are adequately resected, often using a fine rongeur or osteotome.
What about that thin skin you mentioned, if it's compromised?
Ah, yes. A critical consideration in surgical planning is the quality of the overlying skin. If the skin covering the cyst is thin, ulcerated, or otherwise compromised after the cyst and osteophyte are removed, there will be a defect. In such cases, the surgeon must be prepared to perform a full-thickness graft, perhaps harvested from a less visible area like the thenar crease of the palm.
The base of the thumb?
Yes, or to perform a local advancement or rotational flap for skin coverage. This is not merely an aesthetic choice. It is essential to prevent postoperative soft tissue defects, chronic draining sinus tracts, and most importantly, severe infections like septic arthritis.
So you need skin cover skills too.
Absolutely. This highlights the truly interdisciplinary nature of hand surgery, requiring not just orthopedic expertise, but also keen reconstructive plastic surgical principles to ensure robust soft tissue coverage and optimal healing. A poor skin closure can completely undermine an otherwise technically perfect cyst excision.
That's incredibly insightful. It truly underscores a complexity beyond what might appear to be a simple excision. You've mentioned recurrence rates with various treatments, which is obviously a major concern for patients and clinicians alike. Can you elaborate further on the outcomes for different surgical techniques for digital mucous cysts? And are there any newer or adjunctive therapies showing promise that might challenge or change our traditional approach?
Yes, this is important for guiding patient expectations precisely. We know that if a digital mucous cyst is surgically removed without excising its stalk and the underlying osteophyte, the recurrence rate can be alarmingly high, maybe 25% to 50%.
Really high.
Unacceptably high, really. This is why meticulous technique and comprehensive excision are so vital. They are the cornerstone of effective surgical management. However, if the excision does include the stalk, and crucially the underlying osteophyte, the recurrence rate drops to a much more favorable 2%.
2%. That's a huge difference.
Huge. It provides a clear, evidence-based mandate for comprehensive surgical excision as the standard of care. It's a key takeaway that separates successful long-term outcomes from frustrating recurrences. Now, what's truly fascinating here, and a point of considerable clinical discussion, is that DIP joint arthrodesis fusing the joint itself is considered the only way to guarantee virtually no recurrence postoperatively for a digital mucous cyst.
Fusing the joint guarantees no recurrence.
Pretty much, yes. Because arthrodesis completely addresses the underlying joint pathology by obliterating the joint space and its potential to generate more synovial fluid outpourings. It effectively shuts down the source of the cyst. There are various techniques for arthrodesis: Kirschner wires, intraosseous wires, headless or headed compression screws, each with its own profile of risks. Pin tract infections, hardware prominence, dorsal skin necrosis, implant breakage, potential nail deformities.
Trade-offs, as always.
Always. For instance, intraosseous wiring has the highest reported non-union rate at up to 12%, while other techniques generally show more favorable union rates, maybe 92% to 100%. This highlights a significant trade-off for the patient: a higher certainty of cyst non-recurrence, but at the cost of permanent loss of joint mobility at the DIP joint.
A stiff fingertip.
Exactly. The decision for arthrodesis is therefore complex and requires thorough patient counseling, weighing complete cyst eradication against the functional implications of a stiff fused joint. For some patients, especially those relying on fine dexterity, this trade-off is a very difficult conversation.
I can imagine. Are there non-surgical options beyond simple aspiration?
Well, beyond traditional surgical excision, some non-surgical alternatives exist, such as sclerotherapy and cryotherapy. However, these generally have lower efficacy and consequently higher recurrence rates compared to proper surgical excision. More recently, some compelling findings suggest that bleomycin intralesional injection shows comparable efficacy to surgical excision.
Bleomycin, the chemotherapy agent.
Yes, used intralesionally. For instance, recurrence rates for bleomycin injection have been reported around 23.1% compared to maybe 20.0% for surgery in some studies. Patients often report higher satisfaction with bleomycin due to its convenience as an outpatient procedure and reduced side effects compared to surgery.
So a less invasive option with similar recurrence?
Potentially, yes, making it an attractive option, particularly for those who are unwilling or unsuitable for surgery. However, concerns about specific side effects like joint stiffness and skin necrosis with certain sclerosing agents remain, especially given the proximity to adjacent joints and the delicate soft tissues. This area is evolving, and while promising, careful patient selection and a full understanding of the risk-benefit profile are essential. It's not a panacea, but it offers a valuable alternative for certain patients.
Very interesting developments there. Okay, Professor, once a patient undergoes surgery for either arthritis or a mucous cyst, what does the typical postoperative journey look like? And what are the key considerations for rehabilitation to ensure we achieve the best possible functional outcome? The surgery is only one part of the journey, isn't it?
Absolutely. The surgery is indeed just one component of a successful outcome. Postoperatively, a compressive dressing is generally applied to the surgical site to minimize swelling and provide gentle support. This dressing is typically removed after about 2 weeks, at which point the incision site is assessed for primary healing. If there's any particular concern about the quality of the skin flap used for coverage, or if there was a perceived risk of injury to the extensor tendon during surgery, the finger may be immobilized in a splint.
A protective splint.
Yes. This splint is often volarly placed on the palm side to limit any pressure on the incision line and is usually kept on for approximately 10 days to protect the healing tissues from undue stress. Now, a crucial aspect of postoperative care, particularly following any procedure on the DIP joint, is to ensure that the proximal interphalangeal, or PIP joint, is left completely free and unrestricted.
Keep the middle joint moving, even if you operated on the end joint.
Absolutely vital. This might seem counterintuitive, but we actively encourage early and consistent stretching of the PIP joint. The rationale here is to prevent stiffness, which is a common and undesirable complication in hand surgery, especially after immobilization of an adjacent joint. Without proactive range of motion exercises for the PIP joint, patients can develop significant secondary stiffness, impairing overall hand function.
So you fix the DIP but stiffen the PIP. Not ideal.
Not ideal at all. I've seen too many cases where the DIP joint is perfectly fused, but the PIP joint becomes unacceptably stiff, limiting the patient's ability to make a full fist. This targeted approach to rehabilitation is absolutely essential for maintaining the overall fluidity and function of the entire finger, preventing secondary issues. Our hand therapists are invaluable partners in this phase.
That focus on the adjacent PIP joint is a really important clinical pearl. Given the complexity and potential for recurrence, especially with mucous cysts, how do we best educate our patients to manage their expectations and reduce the likelihood of the condition returning after treatment? These conversations must be challenging, requiring a great deal of transparency.
Patient education is absolutely paramount in managing these conditions effectively. We must clearly and unequivocally emphasize the risk of recurrence associated with various treatment techniques. It's about full transparency and ensuring truly informed consent, rather than promising a complete cure that isn't always achievable.
Manage expectations up front.
Exactly. For instance, we highlight that while meticulous surgical excision with comprehensive osteophyte removal is highly effective with a low recurrence rate, non-operative interventions like aspiration alone, or even worse, corticosteroid injections, carry significantly higher recurrence rates. Patients need to understand these probabilities up front to make informed decisions about their treatment pathway and to manage their expectations post-procedure. We discuss the percentages openly.
And what about pain after cyst removal?
Crucially, and this is a point that often gets overlooked in the rush of clinic, it's vital to make sure the patient understands that the underlying cause of their pain might not solely be the cyst itself, but rather the underlying DIP joint osteoarthritis.
Right. The arthritis might still hurt.
Precisely. This distinction is critical because if surgery for the mucous cyst doesn't address that underlying arthritis, for example, if we simply excise the cyst but don't perform an arthrodesis of the DIP joint, they may still experience post-operative pain from the arthritic joint itself. This proactive counseling helps manage expectations and significantly improves patient satisfaction, preventing surprises about residual discomfort or persistent aching after what they might have perceived as a cure for their finger pain.
So you might need to tell them the ick could remain.
You do. I often tell patients, we're fixing the lump, but the underlying wear and tear of the joint will still be there, and that might still ache. It's about presenting a holistic picture of their condition, the interconnectedness of the cyst and the arthritis, and the spectrum of treatment options available, including their respective benefits and limitations. This level of detail empowers patients and builds trust.
That distinction between treating the cyst and the underlying arthritis is so vital for patient satisfaction. Finally, Professor, in a field as intricate as orthopedic hand surgery, what's the role of the interprofessional team in achieving the best possible outcomes for these patients, from diagnosis right through to long-term recovery? It sounds like it's a true collaboration.
What's fascinating here is that the management of digital mucous cysts and finger joint arthritis truly exemplifies the profound benefit of an interprofessional team approach. It really does. While a hand or orthopedic surgeon is undeniably vital for surgical intervention, collaborating seamlessly with other healthcare providers is absolutely essential for comprehensive and optimal patient care. No single clinician works in a vacuum here.
It takes a team.
It really does. This collaborative team includes physiotherapists or occupational therapists who are instrumental for both preoperative conditioning where appropriate and crucial postoperative rehabilitation. Their expertise helps maximize functional recovery, prevent stiffness, and provide specific exercises to restore dexterity.
The hand therapists are key.
Indispensable. General practitioners play a key role in initial diagnosis, often being the first point of contact for patients, and in ongoing pain management, especially for conservative approaches. For specific concerns, such as complex skin issues, or if alternative, less invasive treatments like sclerotherapy are being considered, collaboration with dermatologists can be invaluable, bringing a different perspective.
Different specialists bring different strengths.
Exactly. By working together, understanding the nuances of the underlying pathology, and being acutely aware of the side effects and potential complications of various treatment options across disciplines, we can collectively guide the patient to the most informed decision. This integrated approach allows us to tailor truly comprehensive care plans, which ultimately enhances treatment outcomes, improves long-term patient satisfaction, and builds a robust support system around the patient that extends far beyond the operating theater. It's about shared responsibility and diverse expertise converging for the patient's benefit.
And that brings us to the end of another insightful deep dive. Today, we've unpacked the intricacies of DIP and PIP joint arthritis and digital mucous cysts, exploring everything from their distinct epidemiological profiles and pathophysiological mechanisms to the array of conservative and surgical treatment strategies available. We've highlighted the critical importance of meticulous osteophyte resection in reducing mucous cyst recurrence and considered the nuanced decision-making between joint fusion and arthroplasty for finger arthritis. We truly hope this deep dive has provided you with a clearer, more comprehensive understanding of these common hand conditions, equipping you with valuable insights for your own clinical practice, perhaps even sparking a new approach to a challenging case you're currently facing. To our dedicated listener, if this deep dive has sparked new thoughts or provided valuable clarity, please do consider leaving us a rating and sharing it with your colleagues. Your support helps us continue to bring you these in-depth discussions. Thank you immensely for sharing your profound expertise with us today. It's been an incredibly informative session, and I've certainly learned a great deal.
My pleasure. It's always rewarding to engage in such focused and detailed discussions. Thank you for having me.
So what does this all mean for your clinical practice tomorrow? Perhaps it's a renewed appreciation for the often overlooked details in a patient's nail bed, or a deeper consideration of the why behind that persistent recurrence. Or maybe it's simply a clearer path for that patient who's been waiting for true relief from their nagging finger pain. Until next time, keep exploring, keep learning, and keep diving deep.